Welcome to another episode of InFocus. I'm Jennifer Fuller. February is Heart Month across the United States, a time when advocates and experts try to raise awareness about the risk factors and symptoms of cardiovascular disease, including heart attack and stroke. The first Friday in February is generally designated as Wear Red Day to raise awareness particularly of the risks and symptoms for women, because a lot of times those symptoms don't match what traditional heart attack symptoms are. Two women in Southern Illinois learned that all too well over the last year. I talked with them, Melanie Emery and Beth Roberts, about their experience. They work together at a school district in Southern Illinois and didn't realize about a year ago how much more they would share.
Actually, I woke up, it was a Sunday, and I had pain like all across my chest. It just ached. And I didn't think anything of it. I thought maybe it was heartburn or something. So I just took me a nap and woke up and it was gone. And then Monday was fine. And Tuesday, I woke up with the same pain in my upper shoulder area. And it just kept going. And then my husband told me he was calling the ambulance to come and get me. And we argued for a while. And then I finally said, fine. And but up until then, I hadn't experienced any pain, anything like that. I mean, I'm not the healthiest person by any means, but nothing outrageous or, anything like that. So then they took me to Heron Hospital. The ambulance came and took me to Heron Hospital. And that's when they let me know that I was having a heart attack. And I was cool, calm, and collected. And anybody who knows me knows that's not me, because I panic and freak out and cry. But I was cool, calm, and collected. And they did whatever they had to do at Heron. And then next thing I know, I'm in the ambulance going to Carbondale for a heart cath. And so we get to Carbondale and they had the elevator open waiting on me. And I said, woo, I'm high class, have the elevator here waiting. And they were all laughing about it and telling me that's how they do it at Carbondale. And so they wheeled me in and ended up doing the heart cath. I ended up having 100% blockage and they put 2 stents in. And then I would say that it started probably at 5:45-ish. And by the time my husband called, I got to the hospital, then got to Carbondale and got the heart cath. I was back in the room by 7:30 in recovery after everything had been said and done.
I was just noticed that I have to take the trash can down the road. And it's not like a big hill. It's just like a little hill back and forth up. And I was having trouble pushing the trash can down and bringing it up. I couldn't breathe. I had to stop and go all the time to try to get back up and then catch my breath when I got up to the hill. And that's not like me. So I thought, I better go ahead and call the doctor. So I called the doctor, went to see the cardiologist, and they ran a bunch of tests. And they came out and they said, well, I think you're going to have a stent again. I said, okay, because I have 3 of them already, 2 in my heart and 1 in my kidneys. And I said, okay, I can handle that. Well, they tried to stent me. The stents would not go through. So they said, well, you're going to have bypass surgery. And I said, oh, okay. So then they set it up for like the 8th of July. And I said, if we're going to do it, we've got to do it like right away. I can't wait. I'll back out of it. I know, because it was scary. And so I got to the hospital that morning and changed, and just kind of a calm came over me because they took such good care of me, like Mel said, and Heron and Carbondale was the same way. And the only thing I was worried about, the power going out. Well, what happens if the power goes out when you're on the table and you're on the bypass machine? What do you do, And, but it didn't. I was in there. I was in surgery about 5 or 6 hours, maybe a little bit more, but I came through it with flying colors. I came out, took me a little while to wake up and come off not the respirator, whatever they put in your mouth. And when they finally got that off, I was back to myself. And I got up the next day and started walking in the hospital. And I've been going ever since. I was off about 2.5 weeks from work because I couldn't stand staying at home anymore. I called the doctor and said, you got to send me back. If I can sit at the kitchen table and type for school, I can go to school and work. And so he said, okay, but you got to start half days. That lasted about 2 days. And then I stayed at school all day. But they didn't let me lift or pull or tug or anything. I just got to answer the phone, type and answer the phone. So it worked out really well for me. I came through really well.
I hear from so many people about when they've had their procedure, they didn't realize how bad they felt or how much better they would feel, whether it was a stent or even open heart surgery. Is this your experience as well?
True. That's true. We both agree on that one. That's true.
Yes, because I had been feeling tired and, worn out all the time. And then this happened and I have the 2 stents now and I'm not near as tired as I was before. So
yeah, me either. I can get up the hill now with no trouble. It's good.
A lot of times we hear from women that their symptoms didn't match the traditional symptoms of a heart attack, and they were surprised when they received their diagnosis. Is this your story? Were you surprised?
I was, yes, because I have no family history and nothing. And it took me a while to realize that I really did have a heart attack. And it really did happen.
Yeah, I'm a diabetic, so there's kind of a little difference there because diabetics tend to have more heart troubles. And my dad had a bypass when he was in his 50s, though. I was 68 when I had mine, or 67. So, I kind of would have suspected it because I'm a lot like my dad, but it kind of surprised me that they couldn't get the stent to go through, and they told me I had to have bypass surgery. And especially when they told me when I came out, I had 3. I was really kind of shocked about that.
What would you say to women who are in a similar situation to you in terms of listening to their body, advocating for themselves when they're talking with their doctor or anything like that, in terms of making sure that their care is the best that they can get?
I actually would tell them that they need to go get checked out. I had a friend that asked me what my symptoms were a while back, and I told her, and she goes, well, I kind of feel like that too. And I said, well, go.
Yeah.
I said, don't take a chance. I'd rather go to the hospital and it just be heartburn or panic attack or something like that, and know that that's what it was, instead of just in case it was a heart attack. So I would definitely tell women to make sure you listen to your body. We were just talking about that beforehand, about listening to your body because it knows what's going on, and to go to the doctor when you feel like you don't feel right.
Make an appointment, go to the doctor, and listen to what the doctor tells you. If he tells you you need a procedure done, have it done. And if he says, oh, I would just insist on having it done. It's an important thing because like I said, we both feel so much better.
Mm-hmm.
Melanie and Beth are symbols of patients that cardiologists see all the time. Women who don't recognize that their symptoms and their risk factors may look and feel a little bit different than what they've heard as cardiovascular symptoms in the past. I talked about that with Dr. Rizwan Khan, an interventional cardiologist with Prairie Heart Institute, and he said that there are a lot of things women need to keep in mind.
So essentially from the heart disease standpoint, and specifically we are talking about coronary artery disease right now, many patients who come in with either blockages in the arteries of their heart or if they are presenting with a heart attack. So you're right, it's really highlighted in the media that, the symptoms that women sometimes present with can be more atypical. Essentially, they're not as usual as we are classically used to understanding that, heart disease presents as. But the first thing and the most important thing we need to recognize is that for the most part, even for females too, the most classic symptoms of a patient who's having heart attack are pretty much the same as men are. And the most common ones are that you will have the chest pain, feeling like, there's an elephant sitting on the chest. Sometimes they can have, radiation to the jaw. And so these are the most classic one. And, majority of the females, when they present with a heart attack, they do present with some similar symptoms. But the concern is that one thing that we are slowly recognizing more are that a lot of the times females tend to present, and even though that's a small minor amount, but they do present with some symptoms that are not as classic as these are. And since there are less amount of patients who present with those symptoms, that gets missed sometimes. So they might present with like a feeling that you're having a burning sensation in their epigastric region. They might feel like they're just nauseous, and they might think they just ate something bad, and that's why they're having those symptoms. Sometimes they can have some back pain symptoms or shoulder pain symptoms. Once again, it's less frequent, but that's even more difficult, right? Because when you are not used to seeing those symptoms as frequently, and you are not even, that's not even in your radar that this could be heart disease. And that's what we're trying to highlight more, that whenever we are dealing with a patient coming into the hospital or in clinic with some of the symptoms that might not look like heart issue, but we should always try to think that could it be that? Because this way we're able to catch more patients who could be having a heart attack. So just to give you an example, so this past weekend I was on call, and a patient actually came in with back pain, really bad back pain, as well as nausea. There was some chest pain that it might have been there, but the ER physician very nicely picked it up, got an EKG, and patient was actually having a major heart attack. And I had to open up the blockage to the artery to the front of the heart for that patient. So symptoms, if not classic, we still have to be more open-minded and be more conscious that sometimes females might not present with those classic things.
I talk to women a lot about advocating for themselves, whether it comes to their doctor or just their care in general. How important is that advocacy for women in terms of asking for a specialist or tests when they think that they might be at risk of cardiovascular disease?
I think that's a very important point. So to just give you a little bit of perspective that how, the last few decades, the disparities have been. So classically, when we always think of, heart disease, we always think of, an elderly male person who has some of those traditional risks where they're smoking, they're not taking care of themselves. But we slowly have to come out of that idea now, because what we realized that, and for a certain reason, this was true to a certain extent, because earlier in their life, females don't have as much risk of coronary artery disease or blockages in the arteries as males do. But then as soon as they get to the age where they get menopause, the risk of heart disease really upshoots very quickly. And now we realize that throughout the lifespan of a male and female, the risk is the same. So now you have to think that for males, it's more steady, but for females, it just certainly goes really high, really quick. And because of that, overall, not just in general public, even in healthcare professionals too, there has been a certain bias that when we see a female patient, we might think that it might not be heart disease, and if a similar symptoms a male patient is presenting, we might be more biased to thinking that they could be having heart disease. So that's true that we need to try and have a very high index of suspicions, even with symptoms that are not very classic for heart disease. Especially for females when they hit to that age where the risk is only getting even higher. And I'm glad that it's brought in more and more. And traditionally, we always think of breast cancer when we think of females, but we don't really think of heart disease as much. But heart disease is the #1 killer of the patients from females. And it's almost 7 times more patients die every year due to heart disease than breast cancer. So, we have to keep that in perspective. That and I agree with you that if they are having any symptoms that they're concerned about, definitely advocate for yourself, definitely see and bring up those symptoms. Don't try to dismiss, and even for yourself too. Sometimes I've seen this, that the patients, they try to just justify, when you see them and they're like, oh no, I think this is probably just acid reflux. But then you have to kind of talk them through this, that, it could be that, but acid reflux won't be as dangerous. But if it's truly a heart disease, that can be a very dangerous thing. So you just have to, as a patient perspective too, it's a good idea not to dismiss any symptoms that you're having.
What about risk factors that are specific to women? I'm thinking of things like pregnancy-induced high blood pressure or preeclampsia, those things that maybe are affecting a woman early in their life, but then it comes back later in life. Are these things that are increased risk factors?
Great question, because, classically, when we always talk about the risk factors for heart disease, the biggest ticket items always are, smoking, diabetes, hypertension, obesity, the kind of food and the lifestyle that you have. And it is true for females too. Those are truly the biggest risk factors for females too. But the thing is that more and more we are realizing that there are a lot of specific diseases that females have, especially earlier in their life, that actually has shown that when we look through those patients 10, 15 years down the road, they have a lot more cardiovascular events that happen. And now we're realizing that we need to be more aggressive about screening these people and seeing them earlier. So to give you some example, The most common things, are that during pregnancy, sometimes you can have high blood pressure called gestational hypertension. During pregnancy, you can have high blood sugar levels called gestational diabetes. Oftentimes, they resolve after pregnancy, but they have very high risk of developing chronic hypertension or chronic diabetes down the road, especially for gestational diabetes. Almost 50%, close to 50% of the patients will have diabetes in the next 20 years. So imagine if a patient in their late 20s, early 30s, if they're pregnant and they have this, we have to be really aggressive on making sure we're following them, that they're not getting those issues down the road. More other things like preterm delivery, patients who actually have breast cancer history and they undergo chemotherapy, a lot of those patients end up developing a lot of heart disease down the road. More serious things like preeclampsia is a situation where it's a high blood pressure situation in pregnancy and during the end stages of the pregnancy that can be very catastrophic sometimes. Patients develop swelling in the legs. They also have issues with protein losing in the urine, and they can get kidney failure or liver failure and very bad things due to this. And we found that these patients who actually get preeclampsia, they actually have almost 4 times higher risk of developing heart failure, which is essentially the pump failure of the heart down the road. And they have almost twice as much risk of getting coronary artery disease down the road. So a lot of these risk factors we have to be very conscious about, especially in these pregnant patients. Now, there are other situations, patients who have autoimmune diseases like lupus, they are at high risk of getting coronary disease and other cardiovascular disease down the road. So we have to be very conscious about a lot of these risk factors that are more attributable to females, and understand that, that most of these things are happening earlier in their life, and we are not even thinking about cardiac disease for them, and they will predispose them to have some cardiovascular issues down the road.
When it comes to taking care of your heart health, we hear all the time about mammograms, colonoscopies, pap smears, things that are regular screenings to watch out for specific diseases. But we don't hear about regular screenings for heart disease. Should there be screenings like that?
The problem is that even right now, we struggle with even those patients who actually have high risk of getting heart disease, having the risk factors of smoking, high cholesterol, diabetes, and all those things. Heart disease can be sometimes challenging. And, in a broader group, it's the main 3 issues with the heart disease is, one is the issues with the plumbing of the heart, meaning the blockages in the arteries of the heart. One is the issues with the electrical circuitry of the heart called cardiac rhythm issues. And one is essentially the pump failure of the heart, which means that just heart is not able to pump as much blood forward as it should. And all these things, it's harder to screen them earlier sometimes, even with high-risk patients too. But that shouldn't discourage us from following these patients closely, because oftentimes we're able to catch them before somebody has a heart attack. We're able to catch them before somebody gets really end-stage heart failure. So we want to keep following these patients closely for clinical signs, regular yearly follow-up. And you don't necessarily have to have any lab tests, just clinical signs is a very good picture oftentimes to tell us that if somebody's having an issue or not, and we can start workup with an echocardiogram or with blood work and with EKG and other rhythm monitoring tests to look for all these problems. So the bottom line for these patients specifically is that we just need to mentally be prepared that somebody had a medical issue like this, and they're at high risk of getting coronary disease down the road. So we have to be more diligent about following them closely, making sure they're not having any symptoms that could be an index that they could be getting any of these medical problems.
We talk all the time about how rural America has higher statistics when it comes to those risk factors for cardiovascular disease, whether it's a sedentary lifestyle, increased smoking rates, obesity, diabetes, all of those things. How do you advocate to your patients about these things, which in many cases can be changeable, things that they can make changes to in order to lower their risk of disease? How do you talk to patients about that?
That's actually a very good point. For the most part, cardiac disease, and specifically if we talk about coronary artery disease, issues with blockages in the arteries, they have 2 classic kind of risk factors. One are the ones that we can change. If your parents had heart disease, we can change that. The chances that you can get heart disease are definitely higher with that. The older we get, we can change that. The risk of heart disease is going to be higher. But then all these modifiable risk factors that can start from being able to quit smoking, monitoring the blood pressure and maintaining the blood pressure in a good range, If you have diabetes, then maintaining your blood sugar levels in a good range by making sure that you're taking your medications, you're taking insulin therapy if you have to. From the diet standpoint, of course, decreasing the amount of salt in the diet, decreasing the amount of carb, portion control, and activity standpoint, making sure that we are staying as active as we can. These are the most important things. And obviously, over time, we've seen that they have improved the overall health, but I think there's still a lot of work to be done because I think when we grow up a certain way, it's hard to change those habits. And so we just have to slowly, and from a physician standpoint, our goal is that we try to just keep bringing these things up so that patient at least understand that what it can lead to 10, 15 years down the road.
What about that buddy system? Whether it's a family member or a friend, how should they be advocating both to the patient and perhaps even getting them to the care that they need, watching the symptoms like shortness of breath, fatigue, those sorts of things, and telling that person, hey, you've not been feeling well, maybe you need to get this checked out?
I think that's actually a very good point, and I see this all the time. We end up seeing patients in the ER who should have been in the clinic probably 6 months ago. So, and I think, the awareness that we're slowly trying to create in public and with the Heart Month and with all these different avenues is that the idea that you understand that any symptom that you're having, could it be a sign that you are having heart disease or you're having any cardiovascular issue that needs to be looked at. Majority of the heart problems, they don't, short of somebody suddenly having a heart attack, most of the other medical problems, whether that's heart failure, you'll slowly start getting short of breath. You'll slowly start noticing swelling in the legs. Heart rhythm issues, you'll start noticing some palpitations and feeling your heart is racing faster. And most of the patients, they end up having these symptoms for months before they get to the point that they're really sick. And if you're able to catch them earlier, you're able to alter the timeline of things for them if you treat them. And most of these diseases are very manageable with this day and age and all the technological advances we have right now. It's just that we want to make sure we catch them earlier and start treating them quick instead of seeing them at the very last stage, suddenly when they end up in the ER.
Finally, doctor, what else do you think patients and their caregivers need to know?
From a female health perspective, from cardiovascular standpoint, I think the biggest and most important thing is that we need to just start realizing that cardiovascular disease is probably the most important thing in their health that they need to pay attention to. And the further we get along in life, we need to start very conscious about all these risk factors that we discussed about, and not to dismiss any symptoms. Always, it's better to go to the ER, go to the urgent care, or go to the clinic and be looked at for any symptom that you think might be an acid reflux or something less benign. Because if we miss something, that can be very, from cardiovascular standpoint, that can mean death for some people, which would be a tragic thing.
That'll wrap things up here on InFocus. I'd like to thank Dr. Rizwan Khan of the Prairie Heart Institute, as well as patients Melanie Emery and Beth Roberts for telling their story during Heart Month. You can get more information about Heart Month by talking to your primary care provider or by going to the American Heart Association website at heart.org. From all of us here at InFocus, thanks for joining us. We'll see you next time.